morning or good afternoon, wherever you are. Today, we're very honored to have Professor Daniel Sulmasy, who is going to be talking about continuous deep sedation in palliative care. Um, just a little bit about our speaker. He is the director of the Kennedy Institute of Ethics and a senior research scholar at Georgetown University. He holds a joint appointment at the Pellegrino Center for Clinical Bioethics, and is the inaugural Andre Hellegers Professor of Biomedical Ethics, with co-appointments in the departments of Philosophy and Medicine at Georgetown. His research interests encompass both theoretical and empirical investigations of the ethics of end-of-life decision-making, ethics education, and spirituality in medicine. Without further ado, Professor Sulmasy.
Well, thank you very much. And let me see if I can get us onto full sharing of the screen. So I tried to give a title that's a little more colorful. I'm calling this "The Last Sweet Murmurs of the Dead, Should Physicians Aim at Relieving Suffering by Rendering Patients Unconscious Until Death." Why are any of us interested in this? If you're not aware, by 2015, and I haven't seen any further statistics since, 18% of all patients who died, so that's 1 in 5 approximately in the Netherlands, were treated with continuous deep sedation until death. And that's in addition to the now up to 5.4% of reported deaths by euthanasia. There have been some observers who have even suggested that continuous deep sedation might be functioning as a form of euthanasia that just avoids the paperwork necessary in that country. Part of the problem that we face, I think, is that there are perhaps 50 shades of sedation. There's a practical practice of double effects palliation, which I think has gone on for a long time, where people being given drugs like morphine might unintentionally lose consciousness. But beyond that, there was the introduction maybe 20, 25 years ago of the term terminal sedation. That was thought by some to be too negative, so they suggested we use the term palliative sedation instead, which had a more positive ring to it. Some suggested what we really should say is sedation in the imminently dying, because we don't want to sedate people unless they are imminently dying. Others have talked about what they call proportionate palliative sedation, confusing things even further. Is this really part of double effect or not, if we're aiming at unconsciousness or at least at deep sedation? There's a practice that's been called sedation to unconsciousness. And then finally, as the title for the advertised title for this talk, continuous deep sedation. It's unclear in some ways what all of these terms mean and how they're being used. And under that, in my view, a lot of mischief can actually occur because of the ambiguity. And I hope to relieve us of some of that ambiguity with this presentation. The other big issue has been the introduction of the idea that existential suffering can be used as an indication for sedating someone continuously until they're dead. Lots of people object to that. To do justice to these questions, which is not typically what happens, at least in the medical literature, requires us to do a fairly deep dive into some more basic questions about suffering and perhaps its taxonomy. One question that I think is very important and is almost totally absent from discussions about sedation, palliative sedation, sedation to unconsciousness, continuous deep sedation, whatever we want to call it, is the meaning and value of human consciousness. Where does this fit within our understanding of, particularly of the ethics of this procedure? Also totally absent probably from most of medicine, but particularly from this question, are understandings from the philosophy of medicine about the concept of therapeutics. There has been some interesting work in philosophy of medicine about diagnostics, but little about therapeutics, and sedation is a therapeutic intervention. I want to talk a little bit about different kinds of intentions and the rule of double effect and its role or lack of role in some of these undertakings. So let me start by talking a little bit about suffering. Obviously, we all know, and particularly in palliative care, that not all pain is suffering and not all suffering is pain. And Hans Jonas, in his book, The Phenomenon of Life, I think gets at a deeper sense of what suffering means. He writes that the suffering intrinsic in animal existence, recognizing that you and I as human animals are animals, is not primarily that of pain, which is occasional and a concomitant, but of want and fear. That is, an aspect of appetitive nature as such. So it is an aspect of our nature as creatures that are dependent, that have needs, and in some ways relates to our and a confrontation really with our finitude. Right, when you have arthritis, it may hurt, but arthritis becomes suffering once it becomes a limit for you, and you can't open a jar, for instance. That's when it really becomes suffering. And there are at least two types of suffering that are important, particularly in palliative care. I'll call one neurocognitive and the other agent narrative. You can read a bit about this in a paper that my colleague Lynn Jansen and I wrote quite a few years ago now. By neurocognitive suffering, I mean that which is occasioned by physiological disturbances or disruptions in physical integrity. Right? So if someone has diabetes or they've broken a leg, right? There's a disruption in their physiology, there's a disruption in their physical integrity. And the kinds of suffering that are experienced by persons in this neurocognitive sense, particularly in thinking about them in care at the end of life, prominently pain, of course, but depression, right? Which, if you believe the biological sense of depression with a capital D, is a disturbance in neurotransmitters within the brain. There's a biological basis for depression. Delirium, another disturbed brain state with a biochemical and physiologic explanation. Nausea, seizures, any of those kinds of things, shortness of breath, are what I call neurocognitive occasions of suffering. And these can be distinguished from another kind of suffering which is important at the end of life, that some people have called existential, but I would rather call agent narrative suffering. It's the suffering that's occasioned by disturbances in one's sense of agency, one's narrative history, or one's relationships with other persons. It is often manifested in the kinds of suffering that people experience when they're lonely, or feel alienated, or rejected, or feel guilty, or are in despair, or doubt, or even self-hatred. And it's not as if agent narrative and neurocognitive suffering aren't related. Both can occur simultaneously. Reflection upon one's pain can make one both suffering in an agent narrative sense as well as a neurocognitive sense. But it's important to recognize that these are distinct and that there are different bases for these two kinds of suffering. And if there are different bases, perhaps different approaches therapeutically. A little bit about consciousness. Again, the neglected topic in thinking about rendering people deeply sedated or unconscious. I want to suggest, and I think it should be unarguable, that human consciousness is a higher order human good. It's not a transcendental good like life itself, but consciousness is integral to what it means to flourish as a human being, for us to flourish as the kinds of things that we are, as rational, affective, social, aesthetic, worshiping, free beings. All of these things that make human life special really require in some ways that we're conscious. And so for us to flourish in that way requires some level of consciousness. And consciousness is also necessary for human beings to be able to do good to others, right? To be a spouse, to be a parent, to be a teacher, to be a healthcare professional requires one to be conscious. And so it seems to me unarguable that being conscious is a good thing, but we have to keep our eyes on this when we're thinking about what it's the ethics of making someone sedated at the end of life and diminishing or eliminating their consciousness. Obviously, there are natural diminutions in consciousness, like sleep, but recognize that what sleep is a temporary restorative diminution in consciousness. We sleep or have a restorative or have a temporary diminution in our consciousness in order to be more effectively conscious throughout the rest of the day. And anybody who's ever been a house officer knows that very vividly. Without sleep, it's very hard to be able to act in the world and remain conscious. So, and it's also important to know that sleep, even sleep, is never an unarousable state. It would be a survival disadvantage, thinking evolutionarily, for you to be so deeply unconscious in sleep that you couldn't hear the lion roaring when it came next to you, right? So it's never unarousable, and it is always temporary and restorative. And fatigue, in fact, is a symptom of stress or of illness or of a lack of sleep. And so sleep is something that we need to think about, but make sure that we recognize that it's got differences, distinct differences from continuous sedation until death. Do we ever aim at diminishing our consciousness? Well, I mean, it's natural to aim to go to sleep. People who have trouble do things like count sheep, etc. Sometimes they do take medicines to do it. But again, we aim at this for something that is temporary, and its ultimate aim is restorative. Medically, we can reduce consciousness, for instance, to carry out a procedure. So when somebody undergoes general anesthesia, it's temporary and again part of a restorative plan. It's not the end of everything. It is part of a plan to restore a person. And human beings don't typically aim benevolently at permanently diminishing their own consciousness or that of others. I would be a very bad doctor if I said that every patient who's suffering, I can take care of that by making you unconscious, right? We don't typically aim at permanently diminishing people's consciousness. And the human beings who do aim, even at a temporary state of unconsciousness, in order to dissociate themselves from their agent narrative suffering, are typically thought to suffer from a psychiatric disorder such as substance abuse, right? If you're a heroin addict, you want to make yourself unconscious, and it's often thought a way to escape from the suffering in your life, but it is thought to be an illness itself if we are aiming at that. Foursquare, I want to say that consciousness is also a good thing for persons who are dying. And again, somewhere in the fog of talking about good palliative care, we forget this sometimes to the detriment of our patients and our detriment as an institution of medicine. Maintaining some control over what happens in one's life requires consciousness in order to be able to maintain the kind of dignity that persons will attribute to themselves or to others at the end of life, to be able to participate in medical decision making. To address spiritual issues when people are dying. And again, clinicians in the room will know how serious illness, and particularly at the end of life, raises for patients questions about meaning, value, and relationship, which can be addressed really only if in some ways they're able to maintain consciousness. The palliative care specialist Ira Byock has written a whole book on opportunities for growth at the end of life. Because someone is dying doesn't mean they are less part of the human community, less able to participate in spiritual life or social life. And again, those of us who have been in the business of caring for patients at the end of life know that one of their special roles can be that of teachers. They can teach those of us who survive them important lessons about what it means to be a human being, what it means to be alive and appreciative of that gift. This is known certainly by poets and religious figures. John Greenleaf Whittier, those of you in the UK might not know him, an American romantic poet, more religious than some of the romantic poets in the UK, wrote in this poem, Immortal Love, "The last low whispers of our dead are burdened with his name." The sort of sense that people are still connected, growing spiritually as they are dying. And this is not simply a Western or Christian idea. If you read in the Bhagavad Gita, whatever sphere of being the mind of man may be intent at the time of death. Part of why Buddhists and Hindus, for instance, want in many ways to be conscious so they can be participating in their karmic drama as their life is ending. So the punchline for this section is that consciousness is a human good. And as a general rule, one ought not to intend to diminish a patient's consciousness continually unto death. It shouldn't be our aim. It might be necessary to sometimes. We might accept unconsciousness as an unintended side effect for a very serious reason. And it might be acceptable in extremely rare cases if symptoms have already effectively usurped the patient's consciousness to aim directly at rendering a patient unconscious. But it should be extremely rare, and that threshold should be very hard to reach. And I suspect that 18% of people who are dying don't meet that strict criteria. Philosophy of medicine again requires some attention, particularly if we want to talk about the philosophy of therapy, an underdeveloped feature in the philosophy of medicine. And I have suggested that there are what I call the canons of therapy that are kind of meta rules for therapy that apply to all therapy, end of life, beginning of life, middle of life. And these rules are, or canons are, proportionality, parsimony, restoration, holism, and discretion. To be in a therapeutic relationship with another human being, to do things to that other human being in the trust of a healing relationship, requires attention at all times to these canons: proportionality, parsimony, restoration, holism, and discretion. What do I mean by these? The canon of proportionality, again, if you think about it for a moment, a lot of this sort of makes horse sense to clinicians. It means that the therapeutic response must fit the disease. And there is a way in which this proportionality is both between the means we choose and the end we're seeking, and a proportionality between the benefits and the burdens. So the means-end proportionality means that we have to pick the right treatment for the right disease. So you wouldn't use a butter knife if you want to undergo or want to perform an operation on a patient, right? You need to use the right means. It's got to fit the end you have in mind. And we also want in our therapy to balance the burdens and the benefits of any treatment. I can assure you there are good data that interferon can cure the common cold, but the experience of being treated with interferon is worse than the common cold. It doesn't fit the criteria of burden, benefit, end-to-end proportionality. All therapy should be proportionate both in the means end and the benefit burden sense if we're doing things right. What do I mean by the canon of parsimony? It's basically a rule, again, common sense in therapy that people have not made explicit in many ways. You don't use more therapy than is necessary. There are people who've talked about it before, dating back to Paracelsus. Those of you who are clinicians may recognize that he said all medicines are poisons. Therapy is a matter of dose, right? Again, we all know that. Warfarin is a good example, right? It's a poison. You can use it to kill rats, but you give it in the right amount to a person and it can be therapeutic, right? You don't over-treat treat people. And in fact, this is also part of the art of medicine, and maybe no one has said this more beautifully than Gadamer. In The Enigma of Health, he writes that when therapy goes awry, most often it would not be because physical force or power was lacking or too little was exerted, but rather because there was actually too much force in play. But when the act works, suddenly everything seems to happen spontaneously, lightly, and effortlessly. Genuine success is accomplished in medical practice at just that point where intervention is rendered superfluous and dispensable. All medical efforts at healing are already conceived from the outset in light of the fact that the doctor's contribution consummates itself by disappearing as soon as the equilibrium of health has restored. Parsimony, right? Exactly the right amount, and the patient gets better, and in humility, the healer disappears. The canon of restoration. Therapeutic acts have to have one of two intentions: to either restore right relationship completely to cure the patient, or to restore the right relationship inside the body incompletely so as to mitigate suffering. And that's how we relieve or comfort people. Illnesses are disturbances in the relationships in the body, and healing a patient, treating them therapeutically, either means we completely restore those relationships, or we at least do it partially as to mitigate the patient's suffering. We can sometimes intentionally disrupt relationships, but that's only, again, like disrupting consciousness. It's temporary with a further intention of overall improvement of health for the patient or that of others. So a bone marrow ablation, you might argue, and it's true, disrupts the patient, but the ultimate goal is to give them a transplant afterwards so that they are restored and healed. And research can sometimes disrupt patients or volunteer status in order to benefit people in the future. But by and large, when we're really treating somebody in a clinical setting, we want to restore them either completely or partially in terms of their own physiologic milieu. The canon of holism maybe is a corollary of restoration, and is that normal parts may be permanently removed or functions permanently suppressed only for the sake of the overall survival or flourishing of the individual. Catholic casuists have called this the principle of totality. I think thinking of it as a canon of holism helps people not part of that tradition. So this is what justifies amputating a gangrenous limb, right? So we're taking off part for the sake of restoring as much as we can of the whole of the individual. That's what it means to be therapeutic, even when one is what seems to be diminishing. And then lastly, the canon of discretion. Good therapy must also be respectful of the limits of medicine. And there are two kinds of indiscretions in medical therapy. One is indiscretions of degree, where we overestimate the power of medical therapy. And the second is indiscretions of scope, where we have an expansionist view of medicine's discretionary space, right? So the joke is, at least in the US, I don't know how bad this has become in the UK, but people have said, in this school, the children are sharply divided into those who are gifted and those who are on Ritalin, right? Anybody who's not getting an A needs to be on Ritalin. We medicalize everything and expand the scope of medicine in ways that are not respectful of its limits. And then finally, there are indiscretions of expertise. We can be egoistic or expansionist in the views of our own expertise and overestimate it. I can handle this without a referral. Many people think this is the meaning of the Hippocratic dictum that I will not treat patients with surgery, even if they're suffering from the stone. It is to defer to the expertise of a surgeon, for instance. That's part of the meaning behind that. So restoration, means end, proportionality, and discretion in action. Here's a cartoon. Before we try assisted suicide, Mrs. Rose, let's give the aspirin a chance, right? The least means necessary to treat the patient with the right medicine to restore them to a pain-free state, respectful of the limits of medicine. The last propedeutic here is thinking about intention. And again, people who think about care at the end of life are often sloppy about their thinking about intentions. Some, like Timothy Quill, just dismiss them on the one hand and say they're meaningless, and at the same time go ahead and say that they are actually applying the rule of double effects, so they're even self-contradictory. But it's important to distinguish, I think, these two aspects of what we're intending. One is what contemporary philosophers of mind would call the intention in acting, or we might call in plainer English the end of the act, or in Latin, the finis operis. What's the end of the act that we want to achieve? What are the conditions of fulfillment of our intention? So if I don't know if we can show this on the film here, if we can look for a second. If I throw a pen up in the air and catch it, right? The action is fulfilled when I actually catch it. And even though I almost dropped it on screen, my intention, the end of my action of throwing it up in the pen, I had perhaps a further intention of showing you what intention means, right? But the action itself is fulfilled when I catch the pen, right? That's distinct from our further intention, which is sometimes called the end of the agent, or the finis operantis in Latin. It's the ultimate purpose or motive for which we are acting. And these are distinct aspects of intention that often get conflated in thinking about therapeutics at the end of life. Particularly when we talk about the rule of double effect. I'm one of those people who is prone to dicing and splicing and making things as clear as possible. So even though classically there are only 4 conditions, I've got a lot of extra ones that I put in here because I think they're assumed by people who talk about the rule of double effect, but I want to make sure everybody is clear. One of those things that's often assumed but not classically part of it is that all reasonable alternatives have been exhausted. You don't have to invoke, if you don't have to invoke the rule of double effect, you shouldn't. The second is that you should have an action that actually has 2 effects. And the act itself should be something that's good or at least indifferent. And then, classically, recognize that one effect is bad and the other is good. That the good effect, and here's my language from the previous slide, is the end of the act, not the end of the agent. So it's not ultimately why you're doing it, but it's what you're aiming at in a sort of more immediate sense. And the good and the bad effects can't be mediated by intervening agents. Again, this is sometimes confused by people who say that they give the patient a prescription for life-ending medication and assisted suicide. It's the rule of double effect. They don't intend that they use it. Well, it's the wrong category, right? It's something you are doing, not something that you're assisting in other people doing or cooperating with other people in doing. And then a classical one, you foresee the bad but only intend the good. Classically, again, the bad is not the means by which the good is accomplished. And then going back to my canon of therapy, that the act is proportionate. End to end or effect to effect, balancing the good and the bad is the one that everybody knows about. But also, we ought to be attending to the means end proportionality when we're thinking about double effect as well. So, with all of that, here is a foundational premise for my rest of my argument. Medicine doesn't radically change its aims and methods in palliative therapy. There's this sense sometimes in palliative medicine as if all the previous rules go out the door because the patient is dying. No, absolutely not. The nature of human suffering doesn't change whether the patient has chronic rheumatoid arthritis or they're imminently dying of cancer. Consciousness is no less a human good for someone who is dying. The goals of medicine remain the same, to cure sometimes, to relieve often, and to comfort always. Obviously, they will always be tempered by clinical reality and the art of the possible. And the rules governing therapy don't change just because someone is dying. They'll be governed by the canons of therapy, tailored to clinical reality and realistic goals, and informed by, where necessary, the rule of double effect. And if you think about it, all the real problems in end-of-life care come from failing to follow the basic rules of therapy. So overtreatment is often a problem. When we apply treatments disproportionately, burdening patients with treatments that are really not helpful or more burdensome than beneficial. Non-parsimonious treatment, using too much drug for patients, and indiscretions of degree, failing to recognize the limits of medicine. As Paul Ramsey once pointed out 50 years ago at the beginning of bioethics, the function of medicine is not to relieve the human condition of the human condition. We shouldn't go thinking that we can do everything, that we can relieve all suffering there is in the world. Or there's problems of inadequate symptom control by people who are afraid, for instance, of using opioids out of ignorance of the rule of double effect. And then there's a lot of suffering that comes out of failing to attend to agent narrative suffering in patients. If we concentrate only on the neurocognitive, we're missing important parts of the care of patients who are dying, and it's part of our mission to assure that the agent narrative suffering of patients is addressed as well. So, what should medicine do in end-of-life care? It's what medicine should do in all cases. Recognize all the types of suffering occasioned by the patient's conditions, respond appropriately, and obey the canons of therapy. So, for this audience, this may not be lots of news, but here's the classical way in which people have thought about double effect in morphine, what I call the standard case. What's the intended means we're using? It's the administration of morphine, right? That's what we intend to do. We administer the morphine. The morphine itself, the intended means, we know has two potential actions. One that we're aiming at, the aim of the act or intention in acting, is to relieve the patient's pain. Morphine also has lots of other effects. It can, in rapid intravenous doses, lower the patient's blood pressure. It could make them drowsy. It could give them hives. It could depress respiration and lead to death. Most of the time in palliative medicine, that's not the case. In fact, giving people morphine actually, in most cases, helps people to live longer because it doesn't hurt to breathe anymore. But there are cases, for instance, in someone with COPD or already having other medicines on board, where this becomes real. And we have to consider the possibility that we might unintentionally hasten death. What's the further intention? The aim of the agent, the finis operantis, is to relieve suffering through analgesia, right? The intention in acting is analgesia to relieve pain. The further intention is to relieve the patient's suffering. Standard case of application of rule of double effect. Also, for those of you who believe in just war theory, at least in the conduct of a just war, one also ought to not have undertaken the just war for good reasons, but in the midst of it, one ought to behave in a way that is appropriate and obeys the rules of engagement of the enemy. And one of those cases is strategic bombing, right? Where the bombing itself is intended to eliminate, let's say, weapons of mass destruction. That's the aim of the act. Foreseen, but hopefully not intended, is the death of non-combatants, with the further intention of ending the war sooner. I won't get into whether you think it applies or there is such a thing as just war, but if you do believe it, this is how it works in just war theory. And it fits that well. The intended means has the two effects. It can eliminate the weapons of mass destruction. It can also result in the death of non-combatants. So in classical clinical practice, we have what I would call just plain old double effect sedation, where sedation is an instance of double effect. You give somebody morphine and they are severely ill at the end of life, maybe have other medicines on board, or already because of the illness that they have some diminution in consciousness. You use an appropriate agent for an appropriate symptom, right? So you're using morphine for pain. It's an analgesic that treats pain. Your intention is to relieve the pain. The diminution in consciousness is a foreseen but unintended side effect. The aspirin isn't enough, right? Less risky alternatives are not available, and typically the patient is close to death, right? This is the typical way in which I think for many, many years people have thought about treating patients' pain at the end of life. They're not trying disproportionately to give enough morphine to make the person unconscious, right? You're trying to give enough to relieve their pain. And in fact, it may be that you give enough that they are no longer in pain and can participate in decision making, can do things like talk to their family, be reconciled to loved ones, etc. That's your aim. There may be situations in which it becomes very complicated and you think that it is almost certain that the patient will lose consciousness if you give them, let's say, a benzodiazepine, and that may be a case in which the patient has developed myoclonus, let's say, from high doses of morphine. The only way to stop the myoclonus is to give them a benzodiazepine. In the presence of high doses of morphine, it's extraordinarily likely they will become sedated, and this can contribute to hastening their death. But again, it's the intended means, the benzodiazepine itself, that both is able to stop the myoclonus and has the unfortunate side effect of sedating the patient, or unintended side effect of sedating the patient and potentially hastening death. Fits the rule of double effect in this case. Our further intention, again, is to relieve the patient's suffering, but it's the benzodiazepine itself that gives rise to both the stopping of the myoclonus and the possible unintended side effects. And I think that's another classical application of double effect, where sedation is almost certain to happen. Well, what if you say, I do intend the sedation, but I only intend the sedation to relieve suffering? I don't intend unconsciousness. I do not intend death. And what Quill, Brock, and Meisel have called this is proportionate palliative sedation. And they claim that it's justified by the rule of double effect. I want to say I support this kind of sedation, But I don't think it is supported at all by the rule of double effect, which I can tell you from conversations Quill, Brock, and Meisel don't understand at all. So in this sort of a circumstance, you may be giving a patient a barbiturate with the intention of sedating them, okay? Diminishing their consciousness, but you don't want to give them enough to make them unconscious, right? You only want to sedate them enough to relieve their suffering, even though you foresee the possibility that you might overstep the mark unintentionally and make them unconscious, and that this could potentially hasten their death, all right? You'll notice what we have here is the intended means itself has only one effect, right? There isn't a double effect, right? It is the sedation itself that could cause the unintended effect down the line, but it is not double effect. The one effect of the intended means is sedation. What I would say is that what they're really thinking about is proportionality, is parsimonious treatment here and not proportionality. They want to give just enough medicine to sedate the patient in a way that will help them without intentionally rendering them unconscious. And I think that is something that is also justifiable, but not justified by a double effect, justified by the canon of parsimony, right? In the morphine case, right, you have one effect which causes both analgesia and sedation, one intended means which causes both analgesia and sedation, double effect applies. In the barbiturate case, you may be intending light sedation for relief. You may accidentally or perhaps intentionally give heavy sedation to result in relief, or you may, in fact, intend unconsciousness or unintentionally do so, all according to the dose. So this is parsimony along this one line rather than double effect. It's one effect of sedation in various degrees. So that's parsimonious treatment if you stick with light sedation in order to relieve the patient. Thinking of the possibility that you might accidentally overshoot the mark and make the person unconscious. If you've got a good enough reason for doing that, you may be able to justify it. Now, you may say it's not bad to aim at diminished human consciousness, but again, I want to make a difference between permanent versus temporary and restorative versus non-restorative, aiming at making patients unconscious. Or at least attempting to diminish their state of consciousness. If I use an anxiolytic drug or an anti-epileptic, the effect is, the way that the drug works is to diminish neuroexcitation. The therapeutic effect is, in fact, what I'm aiming at is restoration. The hyperexcitation of anxiety is restored to normal. The hyperexcited state of seizure disorder is restored to normal. Sedation is a side effect. It's often temporary until the patient gets used to the sedating effects, but we can maintain the restorative effects of treating the anxiety disorder or treating the seizure disorder. To aim for more depression of neuroexcitation than is needed to return to normal state of affairs. If that's your aim, then I think you're violating the canon of parsimony, and it suggests an abusive way of thinking about how to go about using analgesics and with a sedating effect or sedative drugs of any sort at the end of life. And there are also cases of respite sedation. I've certainly done this for patients who are in such terrible pain, in such an excited, anxious state they can't sleep. We can use sedative drugs to put them asleep. Temporary, proportionately, not enough to make them totally unconscious, right? So they would stop breathing, but just enough to make them sleepy with an aim of then ending it in order to restore them. Just like the case of a bone marrow ablation before you restore them by giving them a bone marrow transplant. All of those, I think, are justifiable. The new practice, at least in the last few decades, at least maybe 15 years, has been explicitly sedating patients to unconsciousness and death, what I call STUD. Again, as proposed by Quill, Brock, and Meisel, it was claimed, at least in their articles, to be a last resort treatment. However, the Netherlands, being out there on the front ends of all of this, as I told you at the beginning, now euthanize 5% of patients who die, and in another 18% are engaging in this palliative sedation. I would suggest that sedating patients to unconsciousness is not a last resort if 18% of patients suddenly somehow require it. Why it's not an application of the rule of double effect should be pretty simple. You give a patient a barbiturate or propofol or something. Your further intended means is to sedate them, but the ultimate aim of the act is to make the patient unconscious. That's what you're aiming at, is to obliterate their unconsciousness, and that's the intended means of relieving their suffering. So what we ought not to be aiming at, unconsciousness, becomes the very means by which their suffering is relieved, and this can hasten their death. So it's not double effect, because it's not an effect immediately of simply giving the patient the drug. What are the problems with aiming at unconsciousness? Again, except for those rare circumstances like doing it temporarily for respite sedation, aiming to make somebody unconscious, I believe, is a human harm. We should not do this willy-nilly. We should not be doing it to 18% of people who die. Unconsciousness and hastened death are not side effects from this, so it's not double effect. And they're caused by achieving one's intention in acting rather than by the means one has chosen. And so a contradiction from my view ensues. You can't say I'm healing the patient with a harmful side effect, but I'm saying harming the patient is actually the means by which I am healing them. Moreover, I think it violates the canons of therapy. It violates the canon of restoration. There's no sense in which anybody who does this says we're doing it temporarily, or we're trying to make the patient actually better when we're doing it. And it violates the canon of parsimony if less drug would have sufficed in order to treat the patient's suffering. And again, this is being proposed not simply for physical suffering, but for existential or agent narrative suffering. And I think we need to pay attention again to the taxonomy of suffering. We do have a responsibility, both neurocognitive and agent narrative suffering, but our response to agent narrative suffering also should be subject to the canons of therapy. Why is sedation for agent narrative suffering wrong? Well, it's non-parsimonious if less drastic measures could suffice. If bringing the child of the patient to the bedside in order to effect reconciliation would work, why are we sedating the patient who's suffering because they feel alienated from their child? Means-end proportionality is violated. No one who is anxious or fearful or despairing in other walks of life do we think, oh, we should just sedate you to unconsciousness because you are despairing or you are lonely. We don't, it's not the means we use, if you look it up in textbooks, for treating loneliness. It doesn't say barbiturates are there. It denies medicine's restorative goals. It aims at diminished consciousness when spiritual and existential restoration and growth would demand consciousness. And we need to pay attention to the fact that these are part of good palliative care, helping to recognize that patients can still grow at the end of life. And it's indiscreet Somehow I think people are pushed to this because they do think that there must be something in my black box that we can do, in my black bag that I can do to take care of the patient. If they are lonely, if they are fearful, if they are despairing, rather than meeting this with human to human, interpersonal treatment, there must be something I can do pharmacologically. I should use drugs. The one exception, and I think it is possible to conceive of this, is if you were to imagine someone's pain that's refractory to all treatment, yet they're still conscious, and their pain is so severe as to effectively colonize their consciousness, to the point where this is no longer possible for them to do anything. They're in such severe pain, and morphine hasn't helped. Adjunctive therapies like using antidepressants or anti-epileptic drugs hasn't helped. Nothing else is helping for this. And that the pain has already robbed the patient of any possible goods of consciousness, such as saying goodbye, reconciliation, prayer, etc. There might be these kinds of cases in which it would be, in fact, I think, justified, because there one is in a forced choice situation. One isn't trading off making the patient unconsciousness. One's trading off one form of destroyed consciousness for another. The patient either dies with the symptom without consciousness and without consciousness, or the patient dies without the symptom and without consciousness. And thus sedating to unconsciousness at the end of life could be justified, but it would only be for neurocognitive forms of suffering, not for agent narrative suffering where consciousness would be required for means-end proportional therapeutic intervention. And this should be extremely, extremely rare. Opioid-induced hyperalgesia syndromes, for instance, or where giving more opioid makes the pain actually worse and it's not responding to a change in opioids, or adding adjuvant drugs and proportionate sedatives are not effective. And in good hands, from what all I have ever understood from the very best of palliative care doctors, this kind of situation may happen once a year for a full-time palliative care or hospice doctor, not 18% of all deaths. So my conclusions, consciousness is an important human good, even for dying patients. Double effect sedation is common and good and does happen. Parsimonious palliative sedation is also common and good. We're treating someone who's anxious with an anxiolytic drug that could make them a little sleepy, but we're not aiming at sedating them to unconsciousness and death, which in my view is merely a form of slow euthanasia and is wrong. And we shouldn't sedate people for agent narrative existential suffering, because it violates the canons of therapy and is a wrong approach. And the possible exception is these extremely rare cases in which consciousness is already lost due to a neurocognitive symptom. No lesser means will work, and we're in a forced choice situation in which the patient's consciousness is effectively lost either way. They either die with pain or without it, but they're no longer in a state in which they effectively are conscious because of the burden of their symptoms. Maybe then. I'll end with a little painting here, if you've or a reproduction of a large painting. If you've seen Edvard Munch's self-portrait between clock and bed, this is where we all sit. I think that what I've tried to do is say it's complex to live between the clock and the bed. We need to think carefully about what we're doing, particularly using sedating drugs, and try to make the kinds of distinctions that will help us to do better palliative care, both clinically and ethically. And with that, I'll stop, and that should leave us lots of time for questions. So thank you.
Well, thank you very much, Professor, for that talk, and a very arresting image to end on as well. So if anybody would like to ask a question, you can either type a question in the chat, and we have one ready, which I'll come to. Or you can raise your hand either electronically, or you can, in the traditional way, raise your flesh and bone hand for me to see on the video. And I'll come to the question in the chat in a second. But first of all, Fiona Doherty has raised her hand. So if you could unmute and ask directly. Are you there, Fiona?
We lost the camera, but you're still muted.
And still muted. Can you hear us, Fiona? Well, what I'll do, I'll read out the one in the chat, and maybe we'll come back to Fiona. So Josh Briscoe has asked, I may have asked my question too soon as you address it, regarding agent narrative suffering, but it seems the contention is predicated on fundamentally different presuppositions of what medical intervention is for. On the one side, for restoration of health, and on the other, in facilitating a maximizing liberal patient choice. Some have argued regarding euthanasia that the procedure brings coherence to the end of a life they've lived in a way they want it to end. So in that sense, euthanasia restores presumptive wholeness. The needle still needs to be threaded, I think. So I suppose the idea that you're creating your own narrative, which you're giving an ending to.
Yes, I think that we might have some fundamental disagreements about what the end of medicine is. It is not simply to fulfill the autonomous wishes of patients. I mean, there are people who do believe that. In my view, it becomes a reductio ad absurdum. If you've ever seen a picture of the parrot man, medicine can do this. The parrot man decided that he liked his parrot so much he wanted to look like a parrot. So people sewed animal horns into his head, cut off his ears. Plastic surgeons did this. In my view, that's a kind of reductio ad absurdum of the kind of view of medicine as being simply to do whatever medicine is physiologically capable of doing in order to fulfill the autonomous preferences of patients. And it, in fact, in my view, also violates the canon of discretion by overstepping the bounds of what medicine ought to do. So that is a very fundamental disagreement about what medicine is about. But I think that if that's what you think it is, then it leads to all kinds of what I would view to be absurd conclusions. So.
Okay. Fiona, are you with us or? Okay, there seems to be a problem there. Richard Boabeng has his hand up.
Sorry,
Would
can you hear me?
Yes.
Oh, okay. We'll come to Fiona, then Richard, you. Okay. Go for it,
Sorry
Fiona.
about that. Just wanted to thank you so much for that talk. Really interesting distinctions along the way, very carefully carved out. I just wanted to go back to the really interesting way that you circumvented the double effect worry like by kind of just thinking of a single effect in that sense, that sedation was a single effect, and then you had that gradient, the slide where you had the gradient where you had made that into three separate ones: light, heavy, and unconscious. So I was wondering whether you could come back as a proponent of the double effect thesis to say, the gradient that you put along the horizontal axis, you could kind of flip vertically and say that we'll fine grain the act of sedation as there's not just a single thing sedation, but there's light sedation, and there's a kind of like unintended consequence of that, or not principally intended consequence of that, that could lead to unconsciousness. and in that way you'd kind of force it back into the double effect framework, and using the distinction that you made along the horizontal diagram that you had. Just wondering your thoughts about that, because I thought it was a very sophisticated treatment.
Yeah, there are. It's a good question. First, it doesn't matter to me whether we draw the continuum horizontally or vertically. I think part of what you're suggesting, though, is that at each stage there could be other different kinds of side effects that are unintended, right? And that's certainly true for any drug, right? There are different kinds of side effects at different levels. So, for instance, at higher levels of sedation, there's more of a possibility of aspiration than there is at lower levels of sedation. So there are, at each stage along there, different other kinds of side effects. What I was doing was simply thinking of the way in which people were trying to say that sedating someone to unconsciousness, that they were invoking double effect to justify that. And I was saying that there are, and that it was based on the fact that they were treating them with less sedation that was necessary to aim at making them unconscious. And that's all I was trying to sort of say, that along the continuum of consciousness, that doesn't work for double effect. But you're absolutely right that at every stage, for every drug, there are going to be different kinds of unintended side effects that one would have to balance out from using double effect, right? Every drug we use has side effects, right? So there's a 1 in 10,000 chance of anaphylaxis if I give somebody penicillin, right? But I foresee that possibility. Think that treating the patient's infection makes it proportionately beneficial to treat them with that. So all I was doing was sort of saying why it is that the people like Quill, who say that proportionate palliative sedation is double effect, are not correct. What they were really invoking was parsimony in terms of that, and that you're 100% right that there are side effects along the way.
Okay, thank you. Richard Warbank, you had your hand up. Are you okay to speak?
Yeah, thanks, Anthony. Thanks, thank you, Prof Sulmasy. Um, I want to ask. My question is going to be a little bit away from sedation, although still in the medical, space. I'm looking at when you mentioned the canon of parsimony, it occurred to me I was looking at the current medical environment, or the current pharmaceutical, the mindset of profit making, and you mentioned where the healers has to disappear immediately. You make an intervention for a restorative approach or intervention that you make, but you can see that the healer, or the doctor, is still in the same in the process, still giving medication, more medications and more medication, trying to perhaps with the mindset of making profit, and continue. So what would you advise? Because what would you tell today's current health professionals about the concept of the proportionality, and how we can you know I know there's a limit with medicine, has its own limit, and there are other things you can also bring in, so to allow the patient to also have an holistic, care, rather than having this profit making mindset. I mean, look, you can use the American health system for as an example, Prof. And what would you say? What would you advise?
Yeah, lots going on there. Thanks for the question. I think at play are both the canon of parsimony and the canon of discretion. One, in terms of the canon of discretion, is the sort of medicalization, pharmacologization of all of human life, right? There's a drug for everything that is sometimes bought into by lots of people. I mean, drugs are good things. I can keep drinking espresso because we have proton pump inhibitors, and they help for my gastroesophageal reflux disease, right? So I like the fact that those are around. But when we get to ads, like I remember having seen one a few years ago, is it just shyness or is it social anxiety disorder, right? So where we draw the line, how much we keep expanding the limits of what becomes a disease, so that we and that can often be then exacerbated by the profit motive. So that's sort of expanding what my mentor Edmund Pellegrino used to call the discretionary space of medicine, to sort of say it's takes on into account everything. All of human suffering now becomes the bailiwick of medicine, and we should have a drug to fix that. Sadly, when this is fueled by the profit motive, it can become even more harmful to us as a society. And then second, there's the canon of parsimony, right? So if a little drug will help, can't we do more? And again, when people do that, sometimes it's also inflected even as an individual physician sometimes in a for-profit system like the United States. It can be done in ways that are for the benefit of the physician and not the patient. That violates our first duty to use dietetic measures for the benefit of the sick, keeping them from harm, going back to Hippocrates, and to use more treatment than is necessary for profit motives. It makes it even more of a moral problem. So yes, so there are problems inherent in the culture, and the profit motive can just exacerbate both our tendency to be unparsimonious and indiscreet in the use of medicine.
Okay, can I just draw everyone's attention? I put in the chat a link to Professor Sulmasy's paper on this subject, and also a list of his voluminous publications in all sorts of areas. So I do recommend everybody to take a look at them. If I could just ask a slightly different question, but we're talking about the expansion of medicine. I'm just wondering about cases where it might be indicated as a doctor on the medical principles you've enunciated, that you should maybe lightly sedate someone in a particular case, or there's a certain amount of suffering. Yet competing with that is, I don't know, I can think of two kinds of cases. So you could think of a secular case where it would be, it's very, very important that this person reconcile with their family in some sense before they pass on. Yet, purely as a medical matter, your presumption would be that they should be sedated, and that sedation might be to such a degree that they won't be very lucid. And in a religious case, it might be, their last confession or something like that. And it seems to me that there could be conceivably a conflict between what is medically indicated and what the medic should be doing, and what the family or the priest or whoever should be doing. And I'm wondering what your view would be about how to negotiate that kind of thing, because it seems as though there's two ethics involved here.
Yes. So it's always, it's a good question. I think it should always be part of a conversation about informed consent before trying any of these sorts of medications. As a general rule, I think we give wide discretionary space to the patient to be the person who decides the balance and the burdens of those. And there will be some people who say, it would be good for me to reconcile, but
Mhm.
I'm not going to be in a good enough shape to reconcile. In fact, I might be so angry because I'm in such pain that it might be the
Right.
worst thing for me to stay that way. And so please sedate me. And then, so we're in that conversation all the time. Or I might have sometimes the opposite is and it's not just the patient deciding; it's a dialogue, right? So I've had
Mhm.
patients who say, I don't want to take any drugs because they'll make me sedated, and I want to be awake for this to happen. And I can say, I can give you just enough drug to keep you in better shape and allow you to pray, to reconcile with your loved ones, and we can aim for that. We, also share my own limits and the limits of medicine and the uncertainty about this. We might miss the mark. We're going to try our best to do this, but I think that's a dialogue,
Mhm.
and I think there are, outer limits to it, right? So if the patient, and this is where I think the being able to invoke the canons of therapy in the way I have, and the distinction between agent narrative and neurocognitive suffering can come in. The patient says, I've got diabetes. My life is going to be terrible. Please sedate me until I'm dead. Right?
Right. Right.
There's a secular way in which you'd say, the first person's question would say, well, sure, that's your narrative, right?
Yeah. Yeah.
But I think if we can depend upon some more basic sense of what medicine is and what it's for, that we can say, can we talk? Right?
Yeah. Yeah.
You may be mistaken in your views. Although, given that there's nobody better than the patient to be the judge of what the ratio of benefits to burdens are for them. Right? They're the experts in a way that I can't be. But within bounds, within the bounds of good medicine, and not totally unbounded in whatever the patient wants.
Thank you. Helen, what? If you could unmute.
Yes, no, thank you very much for an interesting talk. It just occurred to me there are some research uses of sedation which are not even intended as for the person's benefit, but nonetheless you could think of them as being okay. So you might want to see at what point a drug made someone unconscious. So if that's okay, that's one case where even a healthy person can have
Yes.
a good function temporarily taken away from them. And in the case you mentioned where someone's so overwhelmed by pain that many of the good things they might be able to do aren't available to them, I suppose you could say, yes, sedation is appropriate, but nonetheless, you can't really say that you're making their brain more functional than it was when they were in pain. You're doing a good thing in the sense that you're taking away the pain when their options are so very, very limited. Nonetheless, you are temporarily, in inverted commas, in the sense that you're not. It's only it's temporary in the sense that you're not mutilating them. It just so happens that they'll die before they wake up. You are temporarily taking away a brain function. They're not more functional when they're completely unconscious than when they're awake and in this kind of pain. So I wonder whether sometimes we don't have to bite the bullet and say, as you were suggesting, yes, you can sometimes intend unconsciousness, despite the fact that consciousness is a valuable thing. Whether for research reasons or because the patient has so few options at this particular point.
Yes, you've just given, thanks for the question, you've sort of given me a chance to review again, maybe the slides went through pretty rapidly, some of the exceptions that I did suggest. So there was a slide in I guess you can keep the slides and distribute them to, if you want, to other folks. And you may want to
Oh,
look
thank
at
you. No,
Oh,
I'd
that'd be
love to.
great.
I'd love
Yeah,
to see them.
yeah.
But I did have a slide talking precisely about research. That there may be circumstances in which the benefit is for others, and you're temporarily sedating somebody for the purposes of research. And I thought that was an potential exception. It's still beneficent. It's not beneficent for the individual per se, but they're willing to take that risk, and it's temporary, right? It's not.
Oh, I'm sorry, I missed that. Yeah,
Not permanent. So that's one thing. The second exception I gave was respite sedation, which is I've done and used before too. Somebody who's in a combination of severe pain and inability to sleep, where you sedate them for 8 to 24 hours, right, just to get everything back under control, right? And it's usually would require inpatient care for that to happen, either in an inpatient hospice or a palliative care ward in a hospital. And that can happen too. And again, then after that, you sort of slowly let them back out of it to see if you've been able to strike a balance in which they're restored in terms of the sleeplessness, their pain is under control, and they are able to have at least some consciousness and reasonable pain control. And then the third is, yes, the thing I said is the very last possibility is if you're in a forced choice situation, right? The pain is so severe that their consciousness has effectively been robbed by it, and that can happen. I mean, I've told people who say, "Oh, I don't want to." I don't want to take drugs to eliminate my or diminish my consciousness because I want to unite my suffering to Christ, right? And experience this. And I can say, well, give me just a chance. Just a little bit of morphine can make you feel better and be able to actually engage in a spiritual life again. But it can be in cases in which the pain is so severe that the only way to restore it is either through gradually increasing proportionate palliative sedation until the point where the pain is controlled, right? But then they have been rendered unconscious, which is, I think, the way that it's most frequently done, right? We want to help your pain. We take, with the increasing doses, we take increasing risks, right? We're not aiming at it, but we're trying to get there. And the higher the dose, the closer we're coming to making you unconscious. I think that happens a lot. But there may be, finally, some cases in which there is no way out, right? And that's the one you were talking about, in which there is no further thing we can do for analgesics, and we do aim at unconsciousness, but it's only at the level where we've run out of all other alternatives, and their pain is such that it has effectively robbed them of consciousness. It has colonized their consciousness to a point where we're not trading off consciousness versus unconsciousness. We're effectively trading off two different kinds of unconsciousness, one of which involves much more suffering than the other. But I think those instances would be quite rare, but they're possible.
Okay, are there any other questions or comments? It doesn't look like so. Well, just remains to say thank you very much indeed for an extremely thought-provoking talk and showing how medicine interconnects with so many other fields of life, as it were, and what we need to give consideration for. So I'd like to, if everyone would like to applaud electronically or
Thank you.
or visually, and just to
Thank
say
you.
thank you very much.
Yes, and please, I know it's evening there, but don't go out to happy hour and become unconscious tonight.
One of the few pleasures remaining to us.
Bye-bye
Thank
now.
you very much indeed.